how this was originated. Roberta Newman sent a message to Patty on informing her with excitement that I believe it's her daughter-in-law, has moved to the shore, and that she was a very prominent and active person in the American Diabetes Association, and was encouraging us to reach out to her, and it would be a great way for us on the shore to learn more about diabetes and how we can incorporate the needs for understanding that in all of our policy making and decision making and planning. And Lisa Newman is involved with the ADA's new youth prevention program called Project Power. So Patty did reach out to them, and what came out of that discussion was that Dr. Bonner was recruited to come and give us a presentation today. Joining him is Janelle McDonald. Dr. Bonner is the chair of the Hampton Roads American Diabetes Association Outreach Committee. He's also a former Deputy Secretary for Public Health for Maryland's Department of Health and Mental Hygiene. Janelle McDonald is Director of Development for the ADA's Eastern Territory. With that, I will turn it over to Dr. Bonner and Ms. McDonald, and welcome to the shore in a virtual way, and we look forward to hearing what you have to say.
Well, thank you, Mr. Burton, and thank you, Ms. Kiger, for the invitation to be with you today. And I want to also thank Dr. Schaefer for his warm welcome as well. Thank you, Dr. Schaefer. I'm really delighted to speak with fellow Virginians who have a passion for improving the lives and welfare of all of our citizens. Today, Janelle and I will review the ADA mission, the ADA Bill of Rights, some basic facts about diabetes. Then we'll segue into childhood obesity, and then Janelle will finish with a discussion of Project Power, and I hope we'll have some time for some Q&A. So let me start with the ADA, the American Diabetes Association mission statement. The mission of the American Diabetes Association is to prevent and cure diabetes and to improve the lives of all people affected by diabetes. The vision is a life free of diabetes and all of its burdens. And at the American Diabetes Association, we work hard each and every day with that vision in mind. This year, in the face of the pandemic, the ADA crafted a Health Equity Bill of Rights. And it starts out by saying the preamble is the current health pandemic and its disproportionate toll on minority, low-income, and underserved Americans shines a troubling light on historic, systemic inequities in American healthcare. It is time for health equity now. So this is the ADA Bill of Rights. Number one, the right to access insulin and other drugs affordably. Number two, the right to healthy food. Number three, the right to insurance that covers diabetes management and future cures. Number four, the right not to face stigma or discrimination because of your diagnosis. Number five, the right to avoid preventable amputations. Number six, the right to participate in clinical trials. Number seven, the right to stop pre-diabetes from becoming diabetes. We'll say much more about that a little bit later on. Number eight, the right to build an environment that does not raise the risk of getting diabetes, including safe places to live, to exercise, to clean air, and to clean water. Number nine, the right to the latest medical advances. And number 10, and last but not least, the right to have your voice heard. So as you can see, our mission statement and our Bill of Rights address some of your priority areas as well, including poverty, health literacy, access to healthy food, and access to health care. A particularly important health issue at this time is diabetes, even more so during the COVID-19 pandemic. Diabetes is a major public health problem. There are 34 million Americans with diabetes, and sadly, 10 million of them do not know that they have the disease. So the disease and its complications are progressing undiagnosed and untreated. In addition to that, there are 85 million Americans with prediabetes, 2 million of them right here in the Commonwealth of Virginia. And we'll talk more about the importance of prediabetes a little bit later on. Healthcare costs in this country for the management of diabetes and its complications total more than $240 billion a year. $240 billion a year for diabetes and its complications. In the Commonwealth of Virginia, in addition to having 800,000 individuals with diabetes, there are 35,000 new cases diagnosed every year. As I said before, we have 2 million Virginians living with prediabetes. So it's a major public health problem, without a doubt. It's also a major personal health problem. Every day, 200 or more people go to operating rooms and hospitals around this country to have legs, feet, or toes amputated because of diabetes. It is the major cause of blindness. And every day there are 400,000 people who are on dialysis, primarily because of diabetes and or high blood pressure or both. You can see that the individual has lost a leg because of diabetes, is blind because of diabetes, is on dialysis because of diabetes. This is going to have a major impact on his or her ability to hold a job, on their income, on his or her personal welfare, and on the welfare of his or her family. So it's a major personal health problem. So what is diabetes? Well, diabetes is basically persistently high blood sugar, hyperglycemia, elevated blood sugar. There are two sources of the sugar in our blood. Number one, of course, are the carbohydrates that we eat every day, the sugars and starches. That's the primary source of our blood sugar. And the secondary source is the liver. Our liver is a sugar factory. And that is because between times of eating, that is when we're fasting, in order to make sure that we have a stable blood sugar, the liver continues to put sugar into the blood to maintain a stable level of blood sugar. This is to protect the brain primarily, which is very sensitive to low blood sugar. The blood sugar is in the blood as a means of transport. Its primary function is in the cells of the muscles and other organs, but it needs a second factor, which is insulin, which comes from the pancreas, to move the blood sugar from the blood into the muscle cells, for example. If there's no insulin, this is type 1 diabetes, the blood sugar accumulates because there is no insulin, and in the absence of insulin, the sugar cannot move from the blood into the muscle cells. It accumulates, and this is what we call type 1 diabetes. Much more commonly is type 2 diabetes, in which there is plenty of insulin, but there is resistance to the action of insulin. 90% of diabetics in this country are type 2. That is, they have plenty of insulin, at least to start, but there's resistance to the action of the insulin. The insulin is not effective in moving the sugar from the blood into the muscle cells. It therefore accumulates in the blood, hyperglycemia, and that's the disease we call diabetes mellitus. Diabetes mellitus, diabetes means running water, and mellitus means honey, so it's sweet running water, sweet urine specifically, and that's how it got its name. There is a third form of diabetes, which is called gestational diabetes, which occurs obviously in women during pregnancy. And when they deliver the child, the diabetes goes away. But these women are at risk for type 2 diabetes later on in life, and they should be monitored. Well, how do we make a diagnosis of diabetes? Well, there are two common ways of making the diagnosis today. One is a fasting blood sugar. And a fasting blood sugar of 126 or higher on two separate occasions is a diagnosis of diabetes. The problem with the fasting blood sugar is if I'm a physician looking at a blood test, I'm not sure whether it's a true fasting blood sugar or not, because our blood sugar rises after a meal, and this is normal. A blood sugar after a heavy carbohydrate meal may rise as high as 180, and insulin then comes out in response to this meal, moves the sugar from the blood into the muscle cells, and the blood sugar then gets back to its normal level. So seeing a blood sugar of 160, 180, which can be normal after a meal, but which is definitely abnormal as a fasting blood sugar, causes a problem in terms of interpretation. And so for that reason, we use another measure of blood sugar, which is called the A1C. The A1C correlates with the average blood sugar, but does not vary with meals or exercise. It's stable over time and really reflects the average blood sugar over the past 2 or 3 months. An A1C over 6.5 or higher on two separate occasions is a diagnosis of diabetes. An A1C of 5.7 to 6.4 is prediabetes. Prediabetics are those individuals who have a higher than normal blood sugar, but not high enough to be called diabetes. The problem with these individuals is that even though their blood sugars are not high enough to be called diabetes, the complications associated with diabetes are also progressing undiagnosed and untreated. What are these complications? Why are we so concerned about diabetes? Well, diabetes has a number of serious complications, all of which are related to damage to blood vessels and vital organs, and that's the key. Diabetes causes damage to blood vessels in vital organs. It damages the blood vessels in the brain, resulting in a stroke. It damages the small blood vessels in the eyes, resulting in blindness. It damages the blood vessels to the heart, causing a heart attack. My hero, Jackie Robinson, died at the early age of 53 from blind from diabetes and having had a massive heart attack associated with diabetes at the early age of 53. Just one example of the devastating impact of diabetes. Diabetes damages the small blood vessels of the kidneys, causing kidney failure and resulting in people having to go on dialysis in order to preserve their lives. It damages the blood vessels of the genitalia, resulting in erectile dysfunction. It damages the blood vessels of the legs, resulting in poor circulation, gangrene, necessitating an amputation. And it damages the blood vessels to the nerves, resulting in neuropathy, the pain, the numbness, and tingling that many diabetics suffer from. So you can see this list of complications is daunting, and these are all direct complications of diabetes, which has not been well managed. Now, what are the risks for type 2 diabetes? Well, there's both a genetic and a lifestyle component. The genetic component relates to family history and one's ethnicity, and that can't be changed. So if you have a strong family history of diabetes, or if you happen to be a person of color, it doesn't matter what color, then your risk for diabetes is greater. And on top of that, as we age, our risk for developing diabetes also increases. Well, we cannot change any of these factors. We cannot change our age, our family history, or our ethnicity. But there are two significant lifestyle factors which we can change, at least theoretically. One is our weight, and two is our physical activity. And of the two, our weight is the far more important. The weight that we carry, the excess weight that we carry, particularly the weight that we as men and women carry in our abdomens, both externally and internally, is the bad fat. That excess fat is not just sitting there, it is metabolically active. It's secreting substances that increase insulin resistance. And that's why when one loses weight, either by dieting or by stomach bypass surgery, the diabetes is brought under control, the blood pressure is brought under control, the cholesterol is brought under control. It's not necessary to have bariatric surgery. When a person is overweight and diabetic, simply losing 10% of the body weight is sufficient to get a benefit in terms of control of diabetes. For example, if you're a male and your body weight is 220 pounds and your ideal body weight is 170 pounds, you don't have to get down to your ideal body weight. You don't have to lose 50 pounds. If you lose just 10% of your body weight, which is 22 pounds, you move from 220 pounds to 198, you'll see a significant improvement in the control of your diabetes. So the cornerstone in terms of lifestyle is weight reduction, and that requires dietary restriction, reduction in the number of calories. Now, while the composition of the diet is also of some importance, far more important is reduction in the calories so that the weight is lost. Well, I and many of us recommend the Mediterranean diet as a particularly healthful diet because it's low in fat, low in salt, low in sugar. The keto diet has some adherents, but the problem with that is it's very high in fat, and that poses a risk for premature heart disease. So I do not recommend a keto diet. So diet is the cornerstone of lifestyle change, and the diet prescription must be individualized to that individual. And there's plenty of help available. And we at the American Diabetes Association have online something called My Plate, which will help you to figure out the kinds of foods that you can eat that will help you with this weight loss and thereby reduce your risk of diabetes. Exercise is an adjunct to the diet, and it certainly helps in maintaining the weight and controlling blood sugar, but you cannot outrun your fork. You cannot outrun your fork. Exercise is not a replacement for dietary change. It's a supplement to that. So it's important that you have a dietary change that you can comply with, and added to that then your exercise plan. Once again, individualized exercise plan. And we recommend at least 150 minutes of cardio exercise per week. Now, pre-diabetes is the best opportunity to prevent diabetes and to reduce the risk of complications. These individuals, for the most part, do not require medication. They simply require lifestyle change. So anyone at risk for either diabetes or pre-diabetes ought to know what their risk status is, and they can do that by going online and doing the American Diabetes Risk Test. And if you are at risk for diabetes or pre-diabetes, getting the blood test done by your physician, and then reviewing that to see what your diabetes status is. That is particularly important at this time because both diabetes and high blood sugar are both risk factors for prolonged illness and for death from COVID-19. It's been shown that even in those individuals who do not have a diagnosis of diabetes, who come into the hospital with COVID-19 with high blood sugars, even though they've not been diagnosed as diabetic, these people have worse outcomes, including higher rates of death. So it's really important during this time that you know what your status is in terms of diabetes, whether you are diabetic or pre-diabetic or hopefully normal, but you need to know. And you don't want to go into the hospital not knowing what your status is. So as I said, pre-diabetes is the best opportunity to prevent diabetes and to lower your risk of complications. But nonetheless, whether you're diabetic or pre-diabetic, their prescription for both includes both an individual diet plan and an individual exercise plan. For the pre-diabetic individual, that may be all that they need. And if they're able to maintain that indefinitely, then they may be able to reverse diabetes and remain free of the complications associated with diabetes. But in addition, for the frankly diabetic patient, medication may be required, and there are a variety of medications that are available. Of course, the most common medication used early on in the type 2 diabetic is metformin, an oral medication. And metformin really does nothing in terms of increasing insulin. What it does is it reduces insulin resistance, and it puts a brake on the liver. In almost all diabetics, the liver is overacting, overproducing sugar, and that combined with the increased insulin resistance results in type 2 diabetes. So metformin puts a brake on the liver and reduces insulin resistance, thus allowing for management of the diabetes. But in addition to controlling their diabetes, their blood sugar, the diabetic and the pre-diabetic individual both must control all the other factors that damage blood vessels. These include smoking first and foremost. So they have to control their smoking. The smoking damages the same blood vessels as diabetes and results in the same types of outcomes. They have to control their blood pressure because high blood pressure damages those same blood vessels and causes the same type of complications. And they have to manage their bad cholesterol because cholesterol is implied in all of these blood vessel injuries, and so that must be brought under control as well. So for both the diabetic individual and the pre-diabetic person, you have to know your numbers, your goals, and your plan. And the fact is that for each of these, there is a number associated with the particular factor, and it's easy then to quantify where you are in terms of your current status and your goal. For example, smoking. If I'm smoking 10 cigarettes a day, 10 is the number I'm smoking. My goal is 0, as it should be for all of us. So that's my goal. I'm at 10, my goal is 0, and my plan is to enroll in smoking cessation. If I have high blood pressure, my blood pressure today is 220 over 120, and I know that my goal is 140 over 80, that's my goal, then I have a plan that I've worked out with my physician that includes diet, exercise, and medication. If I have high cholesterol, my LDL is 130, and my goal is 70, then I have a plan for that. Diet, exercise, and medication. If my A1C is 10, and my goal is 7, I have a plan for that. Diet, exercise, in this case, medication. When I get down to A1C of 7, it may be that I can stop the medication and maintain myself at my goal simply by maintaining my diet and exercise program. So it makes it very simple then for the diabetic individual, family, and others to understand the plan for getting to goal for each of these factors that cause complications for the various organs of the body, and thereby to reduce one's risk of these kinds of complications. We're talking about risk reduction. We're not talking about guarantees. We're talking about risk reduction. Let me just speak a little bit more about obesity. 1/3 of American adults are obese. That is to have a body mass index greater than 30. 1/3 of us are overweight, body mass index between 25 and 30. 15% of American children are obese. And in Virginia, 20% of our 2 to 4 year old toddlers are obese. And obesity is linked to a number of chronic diseases, not just diabetes, but high blood pressure, heart disease, stroke, and cancer of various kinds, breast, colon, ovarian, esophageal. So we have a major problem here in terms of weight, specifically obesity. And the causes for this are multifactorial, and you are aware of many of them, as many of them are your areas of concern. They include food deserts, lack of areas for safe exercise, poor eating habits, including missing breakfast, high stress, lack of sleep, and infrequent meals. We at the American Diabetes Association have launched a program to help young children and teens to deal with obesity. And I'm going to turn it over now to my colleague, Janelle, to talk about Project Power. Janelle?
Thank you, Dr. Bonner. And I think you all have received the information, or we can definitely share it out. So I'll kind of go over this overview, and then if you guys have questions, please let us know. So Project Power, one thing that Dr. Bonner talked about was having a plan. And I think anytime you're dealing with any kind of chronic disease management and prevention, education is key. So the American Diabetes Association's Project Power initiative is to slow the trajectory of childhood obesity through health promotion, nutrition education, increased physical activity, and family involvement to prevent obesity. So type 2 diabetes and its complication for youth ages 7 to 13, we feel that this program will help do that with its objectives. So it's got 3 main objectives, and those are to educate, engage, and connect. So we're going to educate the youth at risk for developing type 2 diabetes and their families. We're going to engage those youth and their families in interactive physical activities and nutrition education sessions throughout our different sessions. So also connect the youth to reduce feelings of isolation, increase their social skills, improve their confidence and independence in healthy eating and active lifestyles. And I kind of want to pause on that one for 1 second. We have different in-person camps across the country, typically geared towards kids with type 1 diabetes. And with COVID this year, those camps went virtual. And so it was our Imagine Camp program. So we had a lot of kids with type 1, but also some kids with type 2 involved. And I had participated in that as a camp counselor from one of the sessions. And it was a group around this age, I think about 12 to 14. And they had said, and it was kids from all over the country were partnered in these different cabin groups, very similar to what I'll speak to what we do with Project Power. And one thing that one of the kids had mentioned at the end of the session was that they had become better friends with the group of kids in the session than they had their friends in their area and their schools. And I think that was, to touch on that, connecting these youth. I think youth, of course, kind of that peer pressure, they when they come together and they see other kids doing this, it really helps them feel more connected and I think engaged. It helps us to educate them. And so some of the things that we do, so keeping the kids healthy and active amid the COVID pandemic related to the closures that they've experienced is essential. And so this program is free. It's an at-home online experience, and it consists of fun lessons, physical activity challenges. It starts with they get a Project Power box in the mail, and that includes an activity journal, and that's delivered right to their door. And then the youth can participate in these different activities. So online songs, chants, games, friendly competitions, group meetings with chats and intentional programming in small groups. It's connecting with friends and group leaders during 1-hour sessions twice a week. They can join a virtual cabin and kind of like that camp setup I had talked about. And there's group leaders that will guide interactive activities. They participate in weekly social media challenges, so kind of reaching them where they're at, Instagram, TikTok, Facebook, and then family engagement activities. And so fun challenges, Facebook polls, etc. And I know one thing we've talked about too is not, especially in I think the most important areas to target, not everybody has access to the internet or computers. And so there is a call-in number as well that they can do as long as they have access to a phone. And so ADA Project Power connects and empowers youth to make healthy lifestyle choices, to develop lifelong habits, and encourages those children to develop sustainable, healthy household habits. And I think a lot of times, I've worked with a couple different nonprofits, and when it comes to children, I've heard some really impactful stories about the importance of it starting with the kids, especially lifelong health habits. It starts with the kids. And it's amazing what kids really retain and how they can be the change in a household. And so we just started the sessions back in October, these virtual sessions. So we've already had our first session and we've already began our second session. Our second session started November 3rd and ends November 21st. We are still working on plans for 2021. So at this time, it looks like registration is going to kick off, let me double check, January 19th. And so registration for 2021 sessions will begin January 19th. I'm not sure how many sessions we will have in 2021. I've heard rumors that there will be 5, but that could change, especially depending on how things change with the pandemic. So in the future, would love to see these in person in our area. I think they're of extreme importance. And trying to see if there's anything else that I have missed. And again, I want to reiterate, it's a free program. We've had a great turnout. So across the country, we've had over 600 registered, I think, for the second session. I think the first one may have been just slightly under that. And we do have, I think Virginia is the second state with the next, probably I think Texas had the most kids registered, and then Virginia was the next state to have the next largest amount of kids registered. And what's also great is we have a lot of counselors that are involved, or the guides on these cabin chats are from Virginia. So South University had several, as well as Hampton University. And so really excited about this program. I think it's really important to the kids and their families.
Thank you,
I had anything you wanted to add, Dr. Bonner, that I may have missed?
No, you covered everything. Thank you, Janelle.
Okay, no problem. And I guess if you guys have any questions, we'd be happy to take some questions.
I have one question. Dr. Bonner, as you know, we talked about this a little before you joined us this meeting about the correspondence or the correlation between trauma and diabetes. And I also know, and I'm not sure we included all of this in the introduction, but that you've had a great deal of exposure as an administrator and leader in the national prison system, is it?
Yes, federal.
My question is, did you see a high incidence of diabetes within the prison populations that you worked with?
Yes, thank you for asking that question. Absolutely. I retired from the Federal Bureau of Prisons as a regional medical director. And in that role, I had responsibility for the health care of 40,000 federal inmates in 6 states, including the Commonwealth of Virginia. One of my last accomplishments was to establish a diabetes screening, education, and treatment program in all of 16 of those institutions. By that, I mean that in each institution, we had a diabetes champion, a healthcare professional, pharmacist, psychologist, even dentist, physician, nurse, whatever, who would take responsibility for getting the program off the ground and managing the program in the institution. And then we did an extensive educational program with staff and the inmates to let them know the importance of diabetes, and we share with them much of the information we shared today, so they would understand the importance of us making early diagnosis and getting them into care. And then we were able to successfully get, for those inmates who needed them, glucometers. And if you know anything about prison settings, getting needles inside of a prison is fairly a difficult challenge, but we were able to convince the powers that be this was an important adjunct to their care. And so for those who needed them, we got glucometers. I retired shortly after the implementation of the program. I've been in touch with people since then, and I'm happy to say that the program has continued more or less stronger in some of the institutions than others. But to answer your original question, yes, there's a much higher prevalence of chronic illnesses in the prison population than it is in the population in general, partly due to ethnicity and partly due to lifestyle, partly due to the fact that these individuals have not cared for themselves as we would expect them to do. So for a variety of reasons, also the trauma that they have suffered, depression's also a comorbidity with diabetes. So for all these reasons and others, we have a higher prevalence in the correctional setting of diabetes. And that led to my decision to implement this diabetes screening education program.
Thank you.
Dr. Bonner, this is Bill Payne. I'm president of the Cape Charles Rotary Club, and I'd like to contact you to discuss your speaking at one of our meetings, electronically, of course.
Happy to do so. Thank you.
Thank you.
I have a question.
Yes.
As you mentioned during the pandemic, health people that are at higher risk of certain illnesses are more susceptible to the worst effects of the COVID.
Yes.
And we also know that a lot of people are not going to the doctors like they have in the past because they're basically afraid to go and at risk of getting the virus. So what I understand, the basic way to diagnose diabetes would be to get blood work, and people may be afraid to do that. So is there a way using telemedicine to screen people for risk of that they're maybe pre-diabetic or diabetic? And if so, how can we encourage people as a community to take that at least initial step?
Well, that's a good question as well. I think the first step would be to do the online risk test to see whether, in fact, you are at risk for diabetes. And if the risk test indicates that you are, in fact, at risk, then I think the second thing I would suggest and recommend is that you speak with your physician, healthcare provider telephonically and explain to him or her that you believe that you're at risk. And it may be that there's already been a test done that either confirms or does or says that you're not diabetic within the recent past. There may be some recent work in your medical record that will either confirm this or not. Because even hyperglycemia, pre-diabetes, is a significant risk factor. And to be honest, not all physicians are as aware of this as they should be. And not all physicians are implementing for their patients the kind of interventions that would be helpful. So it may be that in your health record is buried the information that you need to have that will help you know what your status is. If not, I would still urge that people get a laboratory test if it's indicated. If they're at risk and there's no evidence that they've had a recent test and they are at risk, I think the risk benefit in this situation is on the side of getting the laboratory test. Every healthcare institution now is implementing the kinds of precautions necessary to protect people from the transmission of the disease. And so I think that obviously there is some risk, but I think the benefit of knowing one's status in terms of diabetes at this time, in case one is unfortunate enough to contract the disease, far outweighs the risk posed by going into a clinic and getting the blood test done. So that would be my recommendation. Do the risk test, talk to your physician provider telephonically, see if they agree, because they have to order it. If he or she does not order it, it's not going to get done. So it'll end there. But if it were my patient, I would certainly agree to order the test and refer them to a laboratory that I know is carrying out the kinds of precautions necessary to prevent the transmission of the disease. But you cannot underestimate, and you really can't, how significant just hyperglycemia, let alone diabetes, is in terms of bad outcomes. And, so to me, that's the bigger risk.
Dr. Bonner, this is Donna Smith, and I'm with the Eastern Shore Area Agency Community Action Agency. Recently, my staff reached out to purchase and look for a grant to get the meters to actually assist our seniors. Since that time, we only received back, I think maybe about 15, but because of the new freestyle meter that is out, and having to be very knowledgeable of diabetes. My son suffers with diabetes and has had 5 strokes. There's a freestyle meter that is available, but when I reached out to the makers, right at this particular time, they do not have any resources financially to assist. Are you familiar with that freestyle library meter?
Yes, I am. Not in great detail, but yes.
Will you research and help me find some way to get that meter, because it is very user friendly?
Well, I'll speak to my colleagues in the office to see what help they can be in terms of helping you with getting resources for that.
I also recently, probably a few years ago, researched on the EpiPen. The doctors that were servicing my son did not have any information, and I had to find a resource to get that pen. That pen is a very costly pen. So anything that you can maybe direct us to better serve our community on resources, I think that's very helpful to have available, not only for agencies such as ours, but for the medical field. Because I did the legwork to provide to the doctors who were not knowledgeable of what was really cost effective or at no cost. So he received that pen free. But now we moved to another scenario where we are looking to find resources. That the freestyle pen only lasts for 14 days. It's not a long life. And they're running about $35 per pen. Needles, and if you mishap and drop it, you cannot pick it up and use it again.
Right, I understand. All right, so I will do what I can. Yes, thank you.
I have a question for Janelle. I was wondering, I know when I first learned about the project that you were describing, you had some stipends available as incentives for organizations to help recruit students to participate. Is that still going to be a feature in 2021, where moving forward you'll be offering stipends to organizations that either on their own or perhaps partnering with another organization might help with that recruitment?
I'm not aware of it at this time. I think they're still working on 2021 details, because I know we were also talking about there being a technology feature where kids who were in need of like computers, we could find a way to get that to them as well, or internet capability. So I know there's some things that they were talking about, but at this time, I'm not aware of whether or not they've confirmed what they can do for 2021.
Okay.
Sorry. I'll find out, though. I did reach out to one of the directors overseeing Project Power before our call to see if she had more information on 2021, and the only thing she could share was that registration was open January 19th. But as soon as I get that information, I'd be happy to share it with your group.
I really appreciate that. I work on the shore with organizations, but also statewide, and I know the Virginia Partnership on Out of School Time is very interested in helping with that outreach and recruiting organizations themselves who would try to do outreach, and those incentives would really make a difference in getting some people involved, I think.
Yeah, okay, perfect. Thank you.
So are there any more questions? Does anybody have any good ideas of how we can move forward in promoting diabetes awareness on the shore?
And in case I put the risk test in the link for the risk test in the chat box, just so that if people needed that for Dr. Bonner's note.
Thanks.
Thank
I
you.
just posted it on the Healthy Communities Eastern Shore Facebook page
Perfect.
so that people can hopefully share it and spread the word. I think I know for me, sometimes it's within our own organization. We need to do work with our employees to ensure that they stay healthy and we practice good eating habits even at work. Particularly as we're getting near the holidays, it's very tempting to bring in lots of donuts and sugary things.
Yes, we also have the Diabetes Food Hub, just per that note, that has recipes, healthy recipes. So that would be another tool for people and resource for people.
That's great. Thank you. And I know we have books on it as well at the library. Okay, Dr. Schaefer, did you have anything you wanted to add to the meeting?
You know, one of the things that Patty mentioned is I might want to update you on that there was a news event that I was part of earlier today relative to about $20 million coming from Spectrum Charter with the idea that they're going to start connecting about 1,800, I believe, homes in the Onancock area, as well as providing assistance to some other businesses. The big news is, from my vantage point, is that they're going to provide what will be the last mile problem, which is getting it from into the homes of people. I don't know exactly how this is all going to fold out. All I know is that it is moving in the right direction. And people at the event included the governor, Elaine Lauria was there, as well as Linwood and Rob Bloxham. So that doesn't make it a big event, other than the fact that I do think we finally may have made a dent in what I consider to be one of the larger problems on the Eastern Shore, and that is consistent access to the internet. So I would just stay tuned to that.
Thank you. Does anybody have any other announcement for the benefit of the good of the group? Okie dokie. Well, Patty, unless you have anything else to add, I'd like to thank Dr. Bonner and Janelle McDonald for that wonderful presentation. It was very informative. I think even though some of us may have known about diabetes it's always good to have a good overview. And I know it was for me to have it. I get things in piecemeal, but to have that nice, concise presentation and makes it a lot clearer. And we need to be clear ourselves if we're going to be helping to discuss diabetes prevention on the Eastern Shore. So thank you. We appreciate your time. And we look forward to working with y'all more.
Yes, so do we.